actual numerical reduction, not getting to goal, was home BP month.
Just the fact that
Those,
they did.
those two things, yeah,
Their
just that they
patients are
did
engaged.
it just engaged them.
It's engaging
It
them.
was engaging the
Their
patient,
care.
right. And it engaged the doctor, it was more data.
And that's what the, having the non-physician people involved
Yep.
as well.
That's exact, and that was the other thing they found is if there's other individuals, when they looked at the team approach, if there's other individuals involved in the care other than the physician, you were more likely to have a significant reduction in blood pressure. If the patient was doing home monitoring, and there was another thing that they mentioned, I forgot to write it down here. We just had, more frequently seen.
If the patients were more frequently seen.
So, looking at the big problem that that kind of made me kind of like ticked off is like staffing. It's always the
Right,
staffing
right.
thing. Because we never have enough staff.
Right.
And that's always the big concern in my mind when we start to look at some of this other stuff like Brian's working on. It's like, God, we're gonna have the people to be able to do this.
Yeah.
But the work site stuff is very interesting, and there's been for a while the U of R used to have a work site program that was very successful. Do you remember getting that a couple of years back? I think when we were over at Tennessee, we used to get stuff from like Kodak, from docs like Panzer and his group, or somebody from the U of R used to have people over there would check like
Ahmed had a
yeah.
relationship,
Right,
well,
right.
because they got paid, probably.
Right.
Right. But it stopped, but it actually, was actually pretty good. The patients would get their glycohemoglobins at work. They'd get a bunch of stuff done at work. So that's kind of the upshot of the stuff that I found is, the take-home message was blood pressure is not well controlled. And even though when we did our analysis, we were really good, we did it on 2 people. So I don't know what that means. There's an entire universe of people we're not even counting, which are the ones we never see that are our patients.
Yeah.
Most of the
They're all
interventions.
doing home monitoring.
Yeah.
That's good.
Watch it
They're not
going
coming
up
in.
as the left side of the body's not moving anymore. And that the more readings, home readings, frequent office visits, and this work site stuff seems to have a greater tendency, and some sort of a team that's focused on hypertension seems to have a greater impact at reducing blood pressure, possibly getting people to go home.
And along those lines, just as far as getting the patient more involved, for my project for recertification for boards, I did the hypertension project. I had to make some intervention. The intervention I made was to provide the patient the formal DASH diet, and I was very impressed and surprised by how overly receptive the patients were. Not that we haven't talked about diet before, or sometimes but to have that diet and say this is your diet for improving your blood pressure, it's striking. And I've already seen I've gotten some more positive feedback than I thought. I think a lot of it's along the lines of getting them more involved specifically in their
I will say this,
care.
there was a bunch of stuff they looked at. They looked at they looked at a ton of different things in that QI evaluation, and they looked at physician reminders, and they looked at physician education, and they looked at patient reminders, patient education. Everything had an impact. Everything had some kind of an impact at reducing blood pressure, but a lot of them were like 2 millimeters of mercury. Nothing dramatic, so you didn't really get them at goal. But like the JNC7 says, if you can drop their systolic by 2 millimeters, you can reduce their risk by like 15%. So even if not getting them to goal, there's still some benefit to it.
Yes, no.
It's kind of remarkable.
I hesitate saying on anything that's going to be out there in the ether land, but that last article just more evidence that in many ways we are quite ineffective, not only as care deliverers, but as reaching targets. And all that work that we did on looking at anticoagulation protocols, so a lot of the studies came out of pharmaceutical or pharmacist delivered models where they followed those protocols and proved that as pharmacists they were better able to manage patients' anticoagulation than physicians were. And much the same here, that the patients did better where the physician wasn't necessarily the person that was delivering all the care or
Well, it's interesting you say, because in that, when they reviewed, when I said there was only 3 practices that were really community-based, well, there were 3 sites that were pharmacy-based, and they did better than the community-based.
Now, there is obviously a selection bias there because you have highly motivated pharmacists that are being involved and they're trying to prove something. So, of course, there's going to be a little bit of a budge in how they're doing than might be, comparing them to your average Joe. But it is a little disheartening that
Well,
we
you know
don't
what,
do
I
as
think
well as we
it's
would
trying to
hope.
get docs used to being part of a team. They're kind of resistant to that.
That's a good segue into the IHI and the advanced medical home stuff, if you want me to talk about that. But
That sounds like a perfect segue.
so there's a couple of different components that are going on. One is the advanced medical home, and then the other piece is getting NCQA certification. And NCQA has, initially I think they had 6, it was 3 or 6 pathways that you could choose to get certified on. I think there's now 10 or 12. And it's just a certification saying that you've proved that you have high quality outcomes. And with that, there's 2 different groups that are going on. There's what's the PQI piece? Do you remember that, Mike? PCI, PCQI?
No.
I can't remember that acronym. But that's a different group that there's a lot of
Is that the
duplicity
Medicare one you're
between,
talking about?
yeah,
Oh, PRQ,
P-
PQR?
P something.
How do you...
I had it written down.
Another...
PQRI.
PQRI, that's it, yeah.
Get us all together.
That's right. I think it's SPRV.
Elemental P. But anyways, that one actually has a monetary benefit to it. So NCQA, it's a badge of honor. Yip, yip, hooray. PQRI, you get some money back. So we're trying as a network to find a way to make a cafeteria template that you can follow along and get that certification and get qualified for the PQRI so you get some extra money. The advanced medical home is a much larger initiative that's, you guys have probably read about it. National teams are working on getting this going. Both Obama and McCain's camps have talked in their healthcare strategy about pushing the advanced medical home form. So that's reassuring. There's an opportunity for significant monetary improvements in our reimbursement, but with that comes the expectation of not only fee-for-service acute care delivery, but chronic care management. And in that is a template of building these chronic care delivery models through teams and having somebody within your office that is able to integrate with the patient electronically or personally to talk about what their blood pressures are, what their coumadin levels are, what their A1Cs are, what they're eating, what's happening in their life on a more intimate basis than we get in our, every 3 month, every 4 month, every 6 month visits with the patient. So those are some of the big projects that are hanging out there. In terms of quality improvement projects, there's, Highland went through a big thing about, 8 years ago, where they were adopting all these ways of doing quality improvement, and they talked about PDSA cycles. Did you guys ever hear about those? Plan, Do, Study, Act, as PDSA. And so there's a lot of information of, in these groups, IHI and ICIC, which is another quality improvement group, which is the accrediting group of NCQA or PQRI, one of those two. So it gets all muddled in there.
It's the entire alphabet.
But the big thing that they talk about is, if you look at PDSA cycle, Plan, Do, Study, Act, step 1, they say commit to an aim. Make sure that it's clear that you've got a measurable goal, that you've got a population of patients that can fit into that, and that you've got a specific timeline. So that, you need to identify those things. So if we're looking at hypertension, our little mini thing that we did last year, we're looking at hypertension. Who are we going to measure? Diabetics with hypertension. What's our outcome? Did they reach a goal of 140 over 90? I think we used like that. And what's our timeline? 1 year. So that was, we